بسم الله الرحمن الرحيم. السلام عليكم أعزائي الطلبة. This lecture is about poliomyelitis, and this slide showing the disaster result of the poliomyelitis, which is the paralysis. Poliomyelitis can be defined as an acute infectious disease caused by poliovirus, which affecting mainly the anterior horn cells of the spinal cord and the medulla oblongata cranial nerve nuclei. This is the spinal cord and this is the anterior horn cell. Polioviruses are RNA viruses belonging to the Picornaviridae family, and the genus is enteroviruses, and there are three serotypes of polioviruses. These are the type 1, 2, and 3. Polioviruses are extremely hard and can retain infectivity for several days at room temperature. Polioviruses spread from the intestinal tract to the CNS, where they cause aseptic meningitis or poliomyelitis. Epidemiology. The most devastating result of poliovirus infection is the paralysis. Although 90 to 95% of infections are inapparent and induce protective immunity, fortunately. Clinically apparent but non-paralytic illness occurs in about 5% of all infections, while paralytic polio occurring in about 1 in 1,000 infections among infants and about 1 in 100 infections among adolescents. So it is more in adolescent than in infant. In developed countries, prior to the universal vaccinations, the paralytic poliomyelitis occurred primarily in adolescents, while in the developing countries, where poor sanitation and overcrowding are present, the infection usually results in infantile paralysis. This picture shows the difference in the distribution of the poliomyelitis worldwide. So in 1988, the poliomyelitis is endemic in about 125 countries, while in 2017 the endemic countries are only 3, which are the Afghanistan, Pakistan, and Nigeria. Transmission. Humans are the only known reservoir for the poliomyelitis. Spread is by fecal-oral route and sometimes through the pharyngeal secretions. Poliovirus has been isolated from the feces for more than 2 weeks before the paralysis and to several weeks after the onset of the symptoms. The transplacental immunity disappears at a variable rates during the first 4 to 6 months of life. Active immunity after natural infection is probably a lifelong, but protect against the infecting serotypes only, and infections with the other serotypes are possible. Clinical manifestations of poliomyelitis. The incubation period is about 8 to 12 days and ranging from 5 to 35 days. And the poliovirus infections with the wild type virus may follow one of several courses. As we said, inaberrant infections forming about 90 to 95% of the cases and causes no disease and no sequelae, but fortunately induced immunity. Abortive poliomyelitis, consisting about 5% of all infections, while the non-paralytic poliomyelitis, it represents about 1%, and the paralytic poliomyelitis representing about 0.1% of the infections. abortive poliomyelitis, forming about 5% of all the infections, and a non-specific influenza-like symptoms of fever, headache, malaise, and anorexia. These are prominent features, and there may be a sore throat and abdominal pain or muscular pain. The illness is of a short duration, lasting for about 2 to 3 days, and the physical examination may be normal or may reveal a non-specific pharyngitis, abdominal or muscular tenderness, and weakness. Recovery is complete, and there are no neurological signs or sequelae developed in the abortive poliomyelitis. The non-paralytic poliomyelitis, representing about 1% of all the infected patients with the wild-type poliovirus, and signs of abortive poliomyelitis are present, as are more intense headache, nausea, and vomiting, as well as stiffness of the posterior muscles of the neck, the trunk, and limbs. Paralysis of the bladder and constipation are frequent in non-paralytic poliomyelitis. Approximately 2/3 of these children have a short symptom-free interval between the first phase and the second phase, i.e. between the minor illness and the major illness. Nuchal rigidity and spinal rigidity are the basis for the diagnosis of non-paralytic poliomyelitis during the second phase of the disease. So the nuchal rigidity and the spinal rigidity are the basis for the diagnosis of the non-paralytic type of the poliomyelitis. Now the paralytic poliomyelitis, which develops in about 0.1% of all the infected patients and causing 3 clinical recognizable syndromes. These are the spinal paralytic poliomyelitis, bulbar poliomyelitis, and polioencephalitis. The spinal paralytic poliomyelitis, the first phase of which corresponding to the abortive poliomyelitis, and the patient then appears to recover and feel better for about 2 to 5 days, after which a severe headache and fever occur with exacerbation of the previous symptoms. Severe muscular pain also is present, and within 1 to 2 days, asymmetric flaccid paralysis or paresis will develop. Involvement of one leg is most common, followed by involvement of one arm. The proximal areas of the extremities tend to be involved to a greater extent than the distal areas. Examination reveals a nuchal stiffness or rigidity, muscular tenderness. Initially, there will be hyperactive tendon reflexes for a short period only, followed by absence or diminished of the reflexes, and paresis or flaccid paralysis will develop. Sensation is intact, and if there is a sensory disturbance, so we have to suggest other disease other than the poliomyelitis. So the sensation is intact in a case of poliomyelitis, and the presence of sensory disturbance make us thinking about disease other than the poliomyelitis. The paralytic phase of the poliomyelitis is extremely variable, and some patients progress during observation from paresis to paralysis, whereas others recover either slowly or rapidly. The extent of paresis or paralysis is directly related to the extent of the neuronal involvement, and paralysis occurs if more than 50% of the neurons supply the muscles are destroyed, and the extent of involvement is usually obvious within 2 to 3 days. Paralysis of the lower limbs is often accompanied by bowel and bladder dysfunction, ranging from transient incontinence to paralysis with constipation and urinary retention. In the developing countries, the biphasic course is rare, and typically the disease manifests in a single phase. So there is no minor phase and major phase. There is no minor illness and major illness. There is a single phase only, in which the prodromal symptoms and paralysis occurs in a continuous fashion. History of intramuscular injections preceded the paralytic poliomyelitis in about 50 to 60% of the patients, and patients may present initially with fever and paralysis, and this is called propagation paralysis. Once the temperature returns to normal, progression of the paralytic manifestations will stop. Little recovery from paralysis is noted in the first days or weeks, but if it is occur, it usually evident within 6 months. The return of the strength and reflexes is slow and may continue to improve as long as 18 months after the acute disease. Lack of improvement from paralysis within the first several weeks or months after the onset is usually evidence of permanent paralysis. Atrophy of the limb, failure of growth, and deformity are common and are especially evident in the growing child. Diagnosis of poliomyelitis. Poliomyelitis should be considered in any unimmunized or incompletely immunized child with paralytic disease. So if a child presented with a paralytic disease and this child is unimmunized or incompletely immunized, so we have to consider as a case of poliomyelitis. Another, VAPP, which is a vaccine-associated paralytic poliomyelitis, should be considered in any child with paralytic disease occurring within 7 to 14 days after receiving the oral administered polio vaccine, OPV. So, if a patient receiving OPV, if a child receiving OPV, oral polio vaccine, and presented with the paralytic disease within 7 to 14 days, so we have to think about the vaccine-associated paralytic poliomyelitis. The WHO recommends that laboratory diagnosis of poliomyelitis be confirmed by isolation and identification of poliovirus in the stool, with a specific identification of wild type and vaccine type strains. In a suspected case of acute flaccid paralysis, 2 stool specimens should be collected within 24 to 48 hours apart, as soon as possible after the diagnosis of poliomyelitis is suspected. Poliovirus concentrations are high in the stool in the first week after the onset of the paralysis, which is the optimal time for the collection of the stool specimen. Most children with the spinal or bulbospinal poliomyelitis have a constipation, so a rectal straws may be used to obtain specimen, which is ideally a minimum of 8 to 10 grams of stool should be collected. The Csf examination in the poliomyelitis is often normal during the minor illness, and the CNS involvement, and with the CNS involvement typically contain a poliocytosis of 20 to 300 cells per cubic millimeter, and the cells at the beginning will be poliomorphonuclears, but then shift to mononuclear cells soon afterward. By the second week of the major illness, the CSF cells fall to near normal values, but the CSF proteins content is normal or only slightly elevated at the onset of the CNS disease, but usually rises to 50 to 100 milligram per deciliter by the second week of the illness. So by the second week of the illness, the CSF cells will be near normal while the CSF protein will be high. Differential diagnosis of a patient presented with the acute flaccid paralysis or with the paralysis. These including the Guillain-Barré syndrome, acute transverse myelitis, spinal cord compression, trauma or epidural abscess, botulism. In this case, the paralysis will be descending in type from up to down. Also, enteroviral infections will enter in the differential diagnosis of acute flaccid paralysis. Rabies, tetanus, spinal muscular atrophy, like the Werding-Hoffmann disease, myotonic dystrophy, viral poliomyelitis, and hypokalemic periodic paralysis also is one of the differential diagnoses of poliomyelitis. Treatment of poliomyelitis: there is no specific treatment for the poliomyelitis, and the management is only supportive, and it aims to limit the progression of the disease, prevent the ensuing skeletal deformity, and preparing the child and the family for the prolonged treatment required and for the permanent disability if it seems to be likely. All intramuscular injections and surgical procedures are contraindicated during the acute phase of the illness, especially in the first week of the disease, and because they might result in a progression of the disease. Prognosis of a patient with poliomyelitis: the outcome of inapparent and abortive poliomyelitis and aseptic meningitis syndrome is uniformly good, and the outcome of the paralytic disease is determined primarily by the degree and severity of the CNS involvement. In severe bulbar poliomyelitis, the mortality rate may be as high as 60%, whereas in less severe bulbar involvement and or spinal poliomyelitis, the mortality rate varies from 5 to 10%, and death generally occurring from causes other than the polio infections. Prevention of the poliomyelitis, which is the most important thing. Vaccination is the most effective method of preventing the poliomyelitis. Hygienic measures help limit the spread of the infections among young children, and there are two types of the vaccines: the live attenuated oral polio vaccine, Sabin, OPV, and the inactivated polio vaccine, IPV, SALC. Both vaccines induce antibodies against the three strains of the polioviruses. IPV elicits higher serum IgG antibodies titers, but the OPV also induced a mucosal IgA immunity in the oropharynx and the gastrointestinal tract, which limit the replications of the wild viruses at these sites. The immunogenicity of the IPV is not affected by the presence of the maternal antibodies, and the IPV has no adverse effects. Transmission of wild polio virus by the fecal spread is limited in OPV recipients. Live vaccines may undergo reversion to neurovirulence as it multiplies in the human intestinal tract and may cause VAPP, vaccine-associated paralytic poliomyelitis, in recipient or in their contacts. The overall risk of the recipient vary from 1 case per 750,000 immunized infant in the US and 1 in 143,000 immunized infant in India. The WHO used 4 basic strategies to eradicate poliomyelitis globally, and these are: number 1, routine immunization; number 2, national immunization days; Number 3, acute flaccid paralysis surveillance. And number 4, mobile immunizations. The WHO has mandated that infants in all countries still using the bivalent OPV should receive a dose of IPV to offer the protection against the poliovirus type 2. Bivalent OPV is used instead of the trivalent OPV, with the introduction of initially one dose of IPV, injectable polio vaccine or inactivated polio vaccine, followed by the replacement of the bivalent OPV with the IPV. Then notification is a must in a case of poliomyelitis, because the poliomyelitis is a notifiable disease. And thank you for listening.